is signs of, symptoms of an upper motor neuron lesion. So we talked about signs and symptoms of lower motor neuron lesions, and I did a whole PowerPoint on it, and we just don't really have time to do a whole PowerPoint on upper motor neuron lesions. And I'm gonna give you the signs and symptoms of them. So either paresis or paralysis, and so abnormal timing of motor activity, which is just poor motor control. You would have a positive Babinski sign. Y'all remember that? We talked about that with my little niece, checking that. Just rub the bottom of their foot and their toes will fan. Hyperreflexia. So remember, right after spinal cord injury, you have hyporeflexia, right? Whereas here we have hyperreflexia. Abnormal synergy patterns. So that's something we're going to discuss in this PowerPoint, is synergy patterns. And I think there's a couple of good videos on that, so we'll talk about that. And pathologic co-contraction. So, reviewing just what your cerebrum is, up front is our frontal lobe, and remember when we have this central gyrus and we have the motor cortex here, the premotor cortex, and the sensory cortex here on the postcentral gyrus. But then this right here is your limbic system. Your parietal lobe is here, and your occipital lobe is back here. Cerebellum, your medulla, pons, midbrain, thalamus, hypothalamus, here, yeah. There's your aqueduct, the fourth ventricle. Sorry, I didn't teach aqueduct, but that's the fourth ventricle. And then your temporal lobe is hiding back here because of where the slice is on the brain. Okay, so this is the functions. I made this for y'all.
Thank you.
I made a whole chart and just put what their function is. So if you have, your frontal lobe is responsible for decision making, problem solving, conscious thought, attention, emotional and behavioral regulation, speech production. So we think about Broca's area here. So speech production. Personality, intelligence, body movement. So remember that premotor cortex before the motor cortex, it is in your frontal lobe. So your body's ability to plan movement comes from here, okay? And I put Broca's area at the bottom, so you don't have to write it. I mean, it's not good. This is my favorite thing. Okay, parietal lobe. So parietal, we talk about postcentral gyrus where the sensory cortex is, primary sensory cortex. That is what your parietal lobe is responsible for. So your sensory information, touch, pressure, pain, position, vibration, temperature, they are processing that information. It's the processing center. So your spatial processes and your spatial manipulation. The ability to understand three-dimensional space, and so that's your ability to navigate your surroundings. Temporal lobe. So language comprehension, Wernicke's area. So that's reception of language, what you're receiving. Memory, hearing, nonverbal interpretation, like interpreting like nonverbal cues and commands. So like if I move my hands like this, you know what I mean when I do this? You're using your temporal lobe. Sound to visual image conversion. And then your occipital lobe is where your vision center is, okay? So it's important for visual processing, visual data collection, for color, motion, orientation, object and facial recognition, depth perception, distance perception, and mapping. All vision things. It's where it's processing vision. This is my favorite patient to treat. I'm super excited about teaching y'all this stuff. Okay, so what happens when they're injured? So it's basically all of the things that I said, but deficits in those areas, right? So memory issues in the frontal lobe. Your personality is going to change. Your ability to problem solve and make decisions and pay attention. Your emotional and social, they're super socially inappropriate, okay? They're very impulsive. They're the ones that get up out of the bed when they see you walk in the door before you even tell them to get up. Or you put a wheelchair next to them before you can lock the brakes, they're already standing, or trying to stand. So lack of ability to understand or express speech. So they have what is called, if we have Broca's area impaired, it's called expressive aphasia, right? They have the inability to express what they want to say. And that's because they can't control all of this here, okay? Weakness and paralysis and loss of muscles on one side of the body. So flaccid hemiplegia. So it's gonna impact the other side, contralateral side of the body when it's an upper motor neuron lesion. And we talked about that, right? Because all those tracks are gonna cross over. So it's going to impact the opposite side if it's all the way at the top. And y'all remember where that upper motor neuron is? I think I've drawn it a few times. In comparison to your lower motor neuron, it's right on the outside, right? In that gray matter, on the outside of your brain. Okay, so parietal lobe. So memory generation, trouble writing or being able to write, difficulty with math. They can have numbness, disorientation, poor hand-to-eye coordination, inability to identify objects by touch only, so astereognosis. That's what that means, by the way. We talked about stereognosis, right, and how you assess that. So you have a box of goodies and you put your hand in it, you have them close their eyes, and they pick an object up, and they can either tell you or not tell you what's in their hand. So if they can't tell you what's in their hand, they have astereognosia, right? Or astereognosis. And that just means that maybe this area of the brain is impacted, right? Aphasia or apraxia. Apraxia is, yeah.
I was gonna ask, so like, you can get it from deficits in the parietal and frontal, or is it like more one that you can get it with like aphasia?
Typically, what you're gonna see, and what I would mostly ask you, is if it's this aphasia here where it's expressive, or it's temporal and it's here and it's where it's, so you have to understand, there's a difference between, you can't just divide it by this, you also have to divide it by blood vessels. And so some blood vessels, while they may be here, they may also be here, okay? So it doesn't necessarily, there's no cut and dry delineation of that. And then everybody's anatomy is different as well, so you have to understand that too. So there's no cut and dry answer to that, but typically, if you have Broca's area aphasia, it's here. If you have Wernicke's aphasia, it's here. Yeah.
Is it usually like just like one specific lobe that's always gonna be affected by a stroke? Or
No.
just
It could be, we're gonna get even further into this. So we're gonna talk about the different vessels that are impacted. You can have lacunar infarcts, you can have watershed, you can get all kinds of different things that happen. So we're getting there. So with your temporal lobe, you may have hearing deficits, memory issues, difficulty recognizing faces and objects, and then the language impairment with receptive aphasia. And then occipital, you would have difficulty perceiving that one object at the same time, trouble recognizing objects by sight. They may have color blindness, and then they may have visual hallucinations or total blindness. That's kind of hard though. Never really had anybody go total blind. Okay, so now we're gonna talk about
The new Raid Essentials Light Trap uses light to attract, then trap flying insects. Light-powered attraction, insecticide-free protection. Raid, protection for everyone. S.C. Johnson.
Welcome to 2 Minute Neuroscience, where I explain neuroscience topics in 2 minutes or less. In this installment, I will discuss the blood supply of the brain. The internal carotid arteries supply the brain with about 80% of its blood, while the vertebral arteries contribute the remaining 20%. After ascending to the brain, the internal carotid arteries split into the anterior and middle cerebral arteries. The anterior cerebral arteries supply the medial, frontal, and parietal lobes, and they are connected by the anterior communicating artery. The middle cerebral arteries supply most of the lateral surface of the cerebral hemispheres. Before splitting into the middle and anterior cerebral arteries, the internal carotids give rise to the anterior choroidal arteries, which supply a number of different structures, and the posterior communicating arteries, which connect the internal carotid arteries to the posterior cerebral arteries.
form the circle of Willis.
The vertebral arteries give rise to the posterior inferior cerebellar arteries, which supply the inferior surface of the cerebellum, and in most brains will also give rise to the posterior spinal arteries, which supply the posterior spinal cord. The anterior spinal artery, which supplies the anterior spinal cord, also branches off the vertebral arteries. Then the two vertebral arteries come together to form the basilar artery. The basilar artery gives rise to the anterior, inferior, and superior cerebellar arteries, which supply the rest of the cerebellar surface. Then at the level of the midbrain, the basilar artery splits into two posterior cerebral arteries. The posterior cerebral arteries supply the medial and inferior surfaces of the occipital and temporal lobes. The anterior cerebral, internal carotid, and posterior cerebral arteries of both sides of the brain are all connected, forming what is known as the circle of Willis. This interconnection can allow blood flow to continue if a major vessel is blocked on one side of the brain.
Okay, so does that make sense then?
Welcome to 2 Minute Neuroscience, where I simplistically explain neuroscience topics in 2 minutes or less. In this installment, I will discuss
So how blood supply can kind of go into several different of the hemispheres, and where you could have an intermix of symptoms, okay? So now we're gonna talk about disorders of the vascular system, okay? Since we watched the video and we know what arteries we're talking about, we're gonna go through and it's gonna kind of talk about those arteries, okay? So at first, I took and separated things by lobes for you, and now I'm going into arteries, okay? So, loss of blood supply in a specific area correlates with a specific loss of function. So we just talked about that, right? So like, if you lose function from like a PCA stroke, you're not only gonna affect the occipital lobe, you could possibly affect the temporal lobe, and then you're gonna get symptoms from all of those things, okay? And then that's not in the case of subarachnoid hemorrhage. So the subarachnoid space, a hemorrhage would be where the blood vessel pops, right? And there's a bleed. And it would, basically it's telling you it would be in that subarachnoid space, okay? So in the case of that, the loss of function is not correlating to that blood supply. So episodes classified according to both the pattern of progression and stroke type. So that's these. So you can have a transient ischemic attack, which is a brief focal loss of brain function with a full recovery from neurological deficits within 24 hours, okay? And Umford describes it as most of the symptoms vary in duration, but most are resolved within an hour. And within 24 hours, there is full recovery from all of your symptoms.
Is that like a mini stroke?
That's what they'll call it, yeah. That's what a TIA is.
So there's like literally no symptoms after that?
Yeah.
Like it's just
They go away. But if you think about it, if there's ischemia, right, already, and someone's having TIAs, what do you think is really going on? What do you think could occur?
You mean like necrosis?
No, in the sense of like they're at risk, at higher risk of having a large stroke. Right.
So they put them on blood thinners.
Yes,
Generally,
exactly.
right.
They do, but that doesn't always, it just depends on how clogged they are, right? So if they have ICA, which is your internal carotid artery, if it's 90% blocked and they need a thrombectomy, right? They need to go in and clean them out. You know, that person has been having TIAs. They're at risk from the time that they know that that's happening to the time of surgery of throwing a huge clot, right?
Right.
So, or completely occluding the artery. So, these people are typically still at risk of having a larger stroke later on. And then your completed stroke, so this is when those deficits from the vascular disorder that are persistent more than one day and are stable. And a progressive stroke is deficits that intermittently increase over time. So a lot of the language that is used in clinic when we talk about a progressive stroke is, oh, we think that they've had an extension of their stroke. So they've be stable at the hospital in acute care, and they may have sent them over to regional for treatment, and then we notice new deficits or worsening of deficits, and then we see that that stroke has extended, it has progressed. More cell death has occurred. There's a couple different types of stroke. So you have have either an ischemic stroke or a hemorrhagic stroke. Those are your two big types, okay? Your most common is your ischemic stroke. A TIA would be considered ischemic, by the way. And then there are what we call lacunar, or let's talk about this first. So the difference between a thrombus and an embolus, I have a nice little picture up here for you. So you see this thrombus that's stuck to the side of the vessel and it's decreased in blood flow here? Okay, so this is the thrombus. So what happens is, when you have a stroke that's a thrombus, what happens is this is occluded, so distal from this is not getting blood supply. And it causes ischemia and cell death distal from this, okay? With an embolus, what happens is, typically, it comes off of that thrombus here, and the embolus moves, and it goes to the distal segment, and when it can't go any further, it's like a marble that can't go through the water hose any further, right? Then it's stuck, and anything past that is getting ischemic and dying and having cell death. Does that make sense? Okay. Yeah.
So you gotta have an embolus from a thrombus?
Yes. So not necessarily. What could happen, Stephen, is someone could have like atrial fibrillation, and they can throw a clot from their heart all the way up to their lung too, and that would be considered a moving embolus as well.
Okay.
So that's not necessarily, in this example, that's what I'm saying, but it's not necessarily what an embolus could be. Yeah.
So it's what you're saying is like with the DVT, how that can throw.
Yes, that
pulmonary
can throw an embolus, an embolic stroke, which is an ischemic stroke. So there's two different types typically of hemorrhagic strokes. They're the subarachnoid hemorrhage, and then the intracerebral hemorrhage. So intracerebral is gonna be inside the brain, whereas subarachnoid is gonna be in that subarachnoid space. So when do you think you can get a subarachnoid hemorrhage? When could that occur? Or how could that occur? Trauma. Yeah. Fall, motor vehicle accident, any kind of accident, trauma. Is everything I'm saying making sense? If it's not, tell me. Okay. So, have y'all heard of y'all have heard of vascular surgeons, right? So, what they go in and do is they pull this stuff out, okay? I just say they rotor rooter then. They go in and clean it. So what do you think the plaque that builds up in your arteries is from?
Cholesterol.
High cholesterol. Good. So if someone has high cholesterol, they're at risk of stroke. So I just explained the whole thing without even having to, it's on here. So an embolus is a clot that travels, and a thrombus is formed and does not move but blocks the blood flow from behind the blockage. That is the blockage. That might have been better wording. So typically an embolus abruptly deprives an area of blood, resulting in an almost immediate onset of deficits. Whereas a slow occlusion of an artery is different than an abrupt occlusion because it's increasing, it allows for collateral vessels to help with circulation.
So is there like patients that have had strokes and don't know?
No, that's somebody that has cholesterol that builds up, right, and is slowly blocking the vessel, but then your other vessels are picking up the slack, basically. Does that make sense? So, also I didn't talk about lacunar infarct, and I'm sorry, like I'm like backtracking here. But, lacunar infarcts are basically deep inside the brain. They're commonly in your putamen, basal ganglia, thalamus, and internal capsule. And it's obstructions in the small, deep arteries of the brain. And so you see how this could be super bad for a person? Like, because we know the basal ganglia, all of these structures carry, they're white matter typically, a lot of them are, right? Because they're carrying tracks. So they're damaging several things at that point. So when they hit the thalamus, you don't know what part of the thalamus they're hitting, right? So then it's hard to discern what exact area is impaired, right? Because it could be impairing several areas. Yeah.
And I was gonna ask, so like the other vessels have to like make up for the slack, does that cause problems in the other vessels?
It can, yeah, it can weaken them. Well, and if you have cholesterol in one artery, don't you think there might be a little bit in the others
That's what I was
too?
kind of getting, like,
Yeah.
would it be like a domino effect, kind of like?
It can be, and to the point that like, then you have a full occlusion. So a thrombus is obviously less likely than an embolus, right? So the most common type of ischemic stroke is an embolic stroke, not a thrombus. Does that kind of make sense though? Because you're more likely to throw a clot than you are to completely block a whole artery. Unless your cholesterol is just banging bad. And a lot of times what you see with these patients is they haven't gone to the doctor, they haven't gotten their cholesterol checked, or they've had their cholesterol checked, they've been on meds for a really long time, they haven't changed their diet, and then over time, this occurs, okay? And the older we get, obviously, the more likely that this is gonna be a problem.
Does it make a difference that, pain and temperature cross the spinal cord when, like, it crosses as soon as it reaches instead of crossing after the door?
No, because it's still gonna impact the contralateral side, because it's all the way at the top. Does that make sense? So if we're all the way at the top, we're impacting everything below. So it's still gonna be contralateral no matter what. Unless you hit some of those cranial nerves when you have a brain stem stroke. And then you may have some lateral things.
Will that cause different, symptoms on each side?
What do you mean?
Like, you said if it hits all of it, then.
It could hit all of the tracks of that certain area. So like, you're not gonna have an entire, well, I don't say that, but I've had some that really do. You don't have every vessel messed up, basically is what I'm saying. So like, if you have your parietal lobe, it's gonna be your MCA, middle cerebral artery, impacted. So then the blood flow to that area, you're gonna get those symptomologies contralaterally. Does that make sense? So you're gonna have hemisensory deficits. Do I need to do another, like, example?
Yep.
Huh?
Yep.
Yeah.
Okay, so like, if you have premotor cortex, right? That's your ACA, your anterior cerebral artery circulation. We're gonna get to that in a minute. We haven't got that far. But, you're gonna have hemimotor planning deficits, right? And it's gonna be contralateral to the side of the brain that's impacted. So let's say it's a right ACA stroke. You're gonna see that they're gonna have the inability to plan movement on their, what side? Their left side, right? That make sense? Okay. So, intracerebral hemorrhage. I thought this was a pretty decent, understanding of what this is. So downstream blood vessels are deprived of blood and the extravascular blood exerts pressure on the surrounding brain. Does that make sense? Because there's bleeding in the brain and there's only so much space within your brain that when you add extra fluid to it, we're then gonna add pressure. So this type results in the worst deficits when the hours of onset, but they improve really, really well once that edema increases and all of that blood is removed. So you're gonna see that people that have hemorrhagic strokes are going to improve a lot faster than those who have ischemic strokes.
Is that dependent on like how quick they get the blood out or the pressure?
Mm-hmm. How much tissue death there is. Mm-hmm. You have to work fast. So you can't sit at home and just ignore your signs and symptoms. You need to go get seen. So does this make sense how you see the plaque here with ischemia? And you see how there's, cell death distally from that blockage here? Whereas here, there's blood coming out. You see all the blood here, right? And then up here is that subarachnoid hemorrhage. You see we could have trauma here on the skull. And a hemorrhage, of course, is it popping. I just say it's a bleed.
Is that what they call a brain bleed?
Yeah. Mm-hmm. Yeah. So your patients will probably refer to it as that. Like they'll be like, well, I had a brain bleed. You know, because that's typically how the doctor will probably tell them what happened to them. And then that would be a good way of you to describe that to them, right? For you to say, yeah, you had a bleed in one of your vessels. So that helps them kind of understand what's going on. Instead of saying, or they have an embolic stroke, you say, oh, you had a clot that went all the way up to your brain. You know, like just explain it to them that way. So with subarachnoid hemorrhages, it's usually sudden, excruciating headache, loss of consciousness. Initial findings are not focal, so they're not focal to the area that you've hit. Deficits are progressive because of the continued bleeding, and you could have, remember hydrocephalus, right? When there's extra fluid in your brain that's built up, it's not supposed to be there. You could have vasospasms, an infarction. Okay. So now we're going to talk about the signs and symptoms based on the arteries. Yeah, we can take a break.